Hi everyone, my name is Graham and I do some specialist blood test training for Dovetail medical events. And in today's short session, we're going to have a look at understanding INR, International Normalized Range or Ratio, which is a marker of blood clotting. I also deliver specialist training around ECG interpretation, basic ECG interpretation, and also basic bloods and advanced bloods, of which INR is a standalone program, but it can also be embedded within the 1.5 day delivery. So by the end of this short session, we'll have a look at what INR is and why and how it's monitored. We'll have a look at INR and warfarin, and we'll have an overview of the things that could affect INR and when to escalate. And probably most importantly, being able to explain this to a patient. So like we said, all of the delivery that I do is going to be interactive. I'd rather just talk to you about it on the day. We'll draw a few things, we'll take some time to reflect on how it fits in practice, see if what we spoke about fits with your understanding. And there will never be any AI scripts or any kind of AI material. You're just going to get me talking to you about bloods and drawing your expertise and clinical knowledge from the people in the group. So like I did in the other snippet, have a look at that one first, one called Reading the Results. That's helpful to start off with. There are lots of really good resources to have a look at, particularly for INRs. Have a look at what the national guidance says, and then most importantly, how that's locally applied. So although this slide contains some nominal values, it is definitely going to be dependent on each patient, what condition they've got, whether that's atrial fibrillation, whether it's provoked, unprovoked. So this is not medical advice. This is a education workshop where we're linking the blood test to the underlying anatomy and physiology. So always follow the local guidance, link that to the national guidance, and then the GMC registered colleague having the final view on a particular patient as needed. So what is INR? It stands for International Normalized Range or Ratio. So it stands for international, it's used around the world. Normalized range or ratio. And it's a very simple blood test to check how long it takes for your blood to clot. So INR literally measures how long does it take for your blood to clot. In a single arbitrary numerical value. So this is actually derived from another blood test called PT. And this measures the same thing. This also measures how long does it take for your blood to clot, but this time it measures it in seconds. So this is the underpinning test for INR. So if your blood takes between 8 and 12 seconds to clot on the machine, that's normal. So if I move that over to here. So if your PT value is between 8 and 12, that's normal. So that means your blood takes the normal amount of time to clot. So we convert that into an INR of 1. It's a nice and simple blood test. If your INR is 1, your blood takes the normal amount of time to clot. If your INR is 2, your blood takes twice as long to clot. We would like them to form a clot at some point, so we normally have a red flag at 4, 5, 8. So if your INR is 5, that means your blood is taking 5 times longer to clot. And if that's bleeding into a part of your brain or into your spine or into your intestines, that's a long time for blood to be leaking into spaces. So normally, therapeutic doses of INR are around 1.5 to 3, something like that. So we don't normally have INR above 3.5 because it's taking now 4 or 5 times longer for the blood to clot. That's what INR is. And in the session, the longer sessions, we'll have a discussion about that, we'll reflect on that, see if that fits your understanding of patient education. So one of the main aims of all the training that I deliver is to link it back to the underlying anatomy and physiology. So what we do in detail in more time is we'll talk about the liver. And if the liver detects cell damage, like trauma or a bacterial infection, or ongoing cell damage from things like atrial fibrillation, then the liver will release into the bloodstream vitamin K. And this starts a really boring clotting cascade. So there are lots of different clotting factors, one of which is called clotting factor 10A. That is the bit that DOACs work on. We're not going to cover that today, but we'll do that in more detail in the actual program. And then once we've made factor 10A, it's into something called the common clotting pathway. And now we're going to make the blood sticky. So now we're getting into the production of fibrinogen. And fibrinogen is going to start to stick platelets together. So now we're starting to stick these chemicals together. So we're starting to stick platelets and fibrinogen together. And that's going to form a clot, which generally is a very helpful physiological response to damage. So if you cut your finger, there's a bit of blood, and we want to clot it, stop the blood flow, that's helpful. However, in things like atrial fibrillation, cancer, people on long haul flights, people with poor blood flow in their legs, chest infections, sometimes this clotting can get a bit out of hand and can develop into a pulmonary embolism, clot on your lung, a DVT, clot in your leg. That clot might, or plaque might, go for a wander and might stick in your brain, so you develop a stroke, or it might stick in your heart. You might develop a coronary arrest or cardiac problem. So this links all across to other factors, like we said, things like diabetes, hyperlipidemia, hypertension. So have a look at the holistic patient. So if you've got AF, atrial fibrillation, you're likely to have a longer increased risk of stroke. So therefore, we might give you a drug called warfarin. And warfarin will help to suppress vitamin K production. And it interacts with clotting factor production. So therefore, it should take your blood longer to clot because we're interacting with this. So your INR should start to increase. The more warfarin I give you, the more your INR increases. The problem with warfarin is it's slow. It can take 3 to 5 days for your liver to work out it's probably a good idea to start metabolizing warfarin. So if you take warfarin, it could take 3 days before it starts to work. It could take 5 days before it starts to work. Your liver is really good, but it's not necessarily very good at multitasking. So if your liver has to metabolize other drugs, or it has to deal with infection or inflammation, or has to do other things, then it might metabolize warfarin differently. So other health conditions, other drugs, other foods could potentially interact with the warfarin dose. So in summary, we've done the liver is ultimately controlling all of this. Warfarin helps to extend clotting time, and we measure that as INR. So just in summary then, for this section, we've said that INR is actually a standardized PT. So instead of expressing clotting as seconds, which gets a bit confusing when you say it's 12 seconds or 18 seconds, let's just convert that into one. So an INR of 1 means your blood takes the normal amount of time to clot. And if your INR is 2, then your blood takes twice as long to clot. So this allows simple medication around simple numbers. And as you said, there's a range of anticoagulation drugs. Warfarin is only one of them. We could use DOACs, so direct oral anticoagulants like edoxaban, rivaroxaban. We could use drugs that affect platelets like aspirin and clopidogrel. And in hospital settings, we can use things like tinzaparin, heparin. So we'll explore all of those in more detail in the sections. Okay, it's going to depend on what caused the stroke or how long is the stroke or cardiovascular risk. So if you've got AF, that's generally not going to go away. So you tend to be on more longer term treatments. If you've had a blood clot because of an infection or trauma, then as the trauma goes away, you might step off some of the medication. There's also something called bridging, which we'll talk about in the session in more detail, in the full session. Okay, so in the longer session, we'll do some reflective practice. So you might want to pause this video and have a look at these. So questions to reflect on: what is INR? What's it used for? What does an anticoagulation do? How often do you check INR in your setting? What's a normal INR? So what would a normal INR be if you weren't on anticoagulation? And what would be a red flag INR in your setting? Okay, let's have a look at the drug called warfarin. So warfarin recommends warfarin if DOACs can't be used. And the main reason for that is because DOACs are renally cleared, so they're removed by the kidney. So if you've got poor kidney function, then you might not be able to have a DOAC like rivaroxaban or edoxaban. And it's specifically recommended for certain conditions. Some medics use it because of cost, and some because of patient choice. So some patients like to use warfarin. Warfarin comes in lots of different colours, and the colours represent the dose. So a lot of patients don't like the half dose, don't like breaking tablets open. But again, if you're on warfarin long term, part of the role is patient education. You might use a system called INR star or RAT. There's lots of different things we can use. Some patients like taking 3 brown tablets, for example. Some patients like taking 1 blue. So yeah, whatever works for your patient in terms of compliance. Some people like to take 2 white tablets. Some people like to split the brown one in half. So again, have a look at the combination dosing. We might do some baseline bloods. So we'll check the full blood count, liver function, kidney function, do a baseline INR. We might do thyroid function test. We do that in the full session in more detail. Thyroid function also controls clotting. And if relevant, pregnancy and cancer can also significantly affect So again, this is just for initial guidance. Check your locally approved guidance. We'll talk about this in more detail in the session. Most adults with AF, for example, will be on 5 milligrams daily. However, we can adjust that for frailty down to 2 to 3 and even 1 to 2 if people are older adults. And we'll talk about different tools we can use to assess their bleeding risk. Okay, we said that warfarin takes a couple of days to get going. So when we initiate the drug, it might take a couple of days to get going. So check INR normally on day 3. Some people take 3 to 5 days. So check it again on day 5. And then we've got this 3-day regimen. So checking it until it's stable. Then we'll go into the stabilization phase, check it routinely kind of 1 to 2 weeks. And then the maintenance phase, again, it depends on the patient, depends on the reason why, 4 to 12 weeks. Again, check your local approved guidance. The point of this slide, which is the whole point of the training, is to link it back to why is it day 3? Why is it day 5? Because warfarin can take 3 days before it starts to work. So if your protocol says day 4, completely fine, do day 4. It's 4, they pick day 4 because it takes a bit longer. We might also use something called TTR. That stands for time in therapeutic range. So we want your INR to be 2. If we measure it regularly, how often is it within 2? So if it's 100%, if it's 2 every time you measure it, then that's 100% time in therapeutic range. So ideally, we want your INR to be stable. Each condition has its own target INR. And again, these are examples on the screen. The ones used in practice will be given directly by the medic, the consultant, the ANP or nurse-led. So have a look at your specific target INR for different patients. These are just kind of examples. And we'll have a look at warfarin dosing based on their current INR, trend, have they missed any doses, diet or alcohol changes. And a good rule of thumb is adjust the dose slightly if you're using a table or INR star, and try to avoid chasing single abnormal INRs. So a one-off INR blood test that's slightly out may be okay to repeat and just keep them on the warfarin dose. So have a look at single values, don't necessarily need urgent escalation unless they meet the red flag values. Patients will be aware of recording INR and warfarin doses. Whether that looks like, that could be a printout from a system like INR Star. It could be a physical book that they have, and it will have a written information, so they can give that directly to anybody who needs it. And patients will be given specific advice around what to look out for. So what does warfarin do? How often are we going to measure it? Really importantly, any signs of bleeding, if you have a head injury, you fall over, if you notice any bruising, and we'll give them advice specifically around what to do if you miss the dose, if you're unwell, if you're starting a new medication, like an antibiotic, for example. And we'll also talk to them about different foods. So in the longer session, we'll talk about how different types of food can affect warfarin dosage. Again, this is just for guidance, but check your local approved. Normally an INR over 4 or 5 would need escalation. Any new bleeding, any suspected overdose, and if their time in therapeutic range is not stable. So make sure we're really clear on what escalation routes look like. Again, this is just an indication. We'll do this in more detail in the session. There are a range of medical conditions which will affect INR. So generally, liver disease makes your INR go up. Heart failure, particularly chest infections, makes it go up. Acute infections makes it go up, and thyroid function can be very interesting, particularly if somebody's got an underactive thyroid, and then you start treating them with things like levothyroxine, that can then make your INR go up. So again, one of the main aims is, we've got lots of protocols, but linking that back to the underlying anatomy and physiology. So why does thyroid function affect INR? So we can make the patient aware and build the knowledge base. So hopefully this short 20-minute overview has been productive. It'd be great to see you at a future INR session or blood testing session, and you can find more information on the website. Thank you very much.